This podcast is for informational purposes only. It is not intended to provide medical advice. It exists only to entertain.
For historians, for historians, for historians. We look at cases throughout history. You should stare at Alba, Max, and me. You gotta listen, you don't have to read.
Welcome, everyone, to our very first exciting experimental foray into the Curious Case Vault. This is a spin-off show of sorts where we will, from maybe time to time, do our best to figure out what happened in a real case from one of the oldest medical journal archives we can find and try to figure out what practicing medicine was really like back in the day. Some things have changed a lot, others not so much. So we'll figure out what's what nowadays. I'm Dr. Max, and I'll be joined by Dr. Aaron as we play the roles of medical Jedi to our medical history intern and enthusiastic Padawan learner who did all the real work for the show today, Alba. Hi, Alba.
Hey, I'm really excited. Thanks for having me do this.
For the Jedi, she's the medical history Padawan, Max. I feel like that was right there.
I did. Well, I said
Padawan?
enthusiastic Padawan learner.
Yeah. Did you?
Yeah.
And I missed it?
You did.
Better than a wait, is a Padawan and a Jedi?
Padawan's
which
like
one's higher?
It's like the resident of the
Okay.
Jedi world to the attending. The Jedis are attendings, Padawans are residents.
And I
Gotcha,
missed it.
okay.
Yeah. All right. Good job, Max. Good job. Way to be in there. Good job. All right. Here we go.
Missed that kind of reference.
Yeah.
All right. So, Alba, you found and studied a case from very long ago, and we're going to try to help figure out what happened and sort of sort through what it all means. And
Was it far, far away too?
no, it wasn't.
It was a long
It
time
was in
ago.
this
No.
galaxy, Aaron.
Oh.
When and where is today's case coming from, Alba?
The year is 1841, and the where is West London.
All right. So this came from what, the British Medical Journal, I believe.
Yeah.
I think that's where we found it. So yeah. So what's
How
this
do I know
case?
where it- So yeah, we have a case. Dr. Jordan Roche Lynch is the doctor who first encountered this patient. The man's name was John Whaler. He's a 53-year-old male, and he called requesting a home visit.
Really weird, by the
And-
way, is you don't see in modern journals is putting a patient's name in a publication is really jarring. You do see that back in this time, but it is not common.
Yeah, that's a
So this, yeah,
that's a
no,
no-no
but,
now.
Yeah, no, old John Whaler. All right.
Good old HIPAA. So he called for a home visit. So that's what doctors. There was a lot of that going on back then. The come on to my house. I'm not feeling so good.
Yeah.
And the chief complaint was he had a sudden onset of severe pain, tenderness, and a feeling of constriction in his throat.
Throat or throat? I feel like it's throat in
His
West
throat.
End London.
Oh, I'm so sorry. Yes, the patient has an onset of severe pain and tenderness and constriction in the throat.
You absolutely
in
do not
it.
have to do the whole case that way. I was just
No, okay. Oh, thank
I
God.
appreciate the effort.
I was going to commit to the
I
bit.
know you would.
Now, I noticed good old Dr. Lynch wrote severe pain and tenderness, or he didn't even write severe, but pain and
Ooh.
tenderness. And I thought, aren't those the same thing?
Oh, Alba.
No,
Alba,
no.
Alba.
Oh, dang.
No,
Ugh,
no,
I got
look,
a lot to learn.
Here's the thing. Here's the difference. So this, if we were your actual attendings, at some point you were a
Mhm.
medical student, you wouldn't have had the consciousness to ask before saying this. You would have assumed that they were the same thing, and then some snarky attending would have pulled them apart and held these two terms in front of you to explain what the difference is. And I'm not that guy, but Aaron is. So Aaron, please.
Okay. All right. I'm ready,
Let's
Aaron.
not- no, I'm
Rip
not
me
gonna-
a new one.
I'm not gonna rip.
Okay, but so there's
there-
actually a difference.
Yeah, there are signs and there are symptoms. So symptoms are what the patient describes, and signs are what you find on physical exam, right? So
Okay.
generally,
So tenderness is a finding.
Right. So you push
Correct.
on it, it hurts. And then the patient is saying, I have pain and constriction. And that's important because sometimes you might, for example, you can have poor blood flow to your intestine. And the patient might say, I have this terrible pain in my stomach. And when you push on their belly, it's actually not that soft. So that's called pain out of proportion to your exam. And that's a sign there's something going on that kind of leads you down a specific pathway. So it's like that. It is a useful distinction.
Yeah.
So
yeah. So I had to stop because it's every medical student and resident has somehow come across this. But yeah, so all right, please do continue. So
that's great. Good
so basically,
to
the patient's saying his throat hurts, and the physician is saying it was tender when I touched it and pressed on the throat.
Gotcha. Okay. So then Dr. Lynch goes to his home, and when he gets there, he finds a patient that is in what I considered obviously acute, he says the patient obviously has acute laryngitis, is what he said.
Obviously.
He's like, it's pretty clear. He's in acute distress. And the way that the doctor described it is he's anxious in the extreme, eyes staring, nostrils flared, all of those things going on. And then also that he's also not able to speak louder than a whisper. It sounds like his breathing is labored, though I maybe interprered that from the nostrils.
I would agree with I read through. Yeah, I would agree.
I'm not liking this story. It's a bad story.
He's not feeling too good. This guy's having a hard time. So Strider is audible in the room and even outside of the room. And I cannot, I could imitate what I think Strider sounds like, but I don't know.
It's an obvious Lord of the Rings reference. He's a ranger that comes out of the north. No. Okay.
Oh.
No. Okay. No.
That's
All right. Sorry. No, Strider is not that.
Yeah. So Strider is definitely one of those sounds.
Yeah.
Yeah. It's one of those sounds that you hear as an emergency doctor and you're like, that's bad. Yeah. It's like breathing through a straw.
Oh, that's better. That one's even worse.
It can sound a variety of different ways, and it can be mild, and sometimes you only hear it when they inhale, or you only hear it when they exhale. But it's one of those things that when you hear it, especially as a probably then, but now as a modern ER doctor especially, you're like, oh man, there's an airway problem. And that means that there is we got to fix it now or very soon problem. And I think the most common way that you might hear Strider, if you're not an ER doctor, we've almost probably all had or been around somebody who's had it as a child, because it is one of the common things you hear with an illness called croup. Have you ever heard of that, Alba?
Vaguely and rarely it's popped up, but I don't really know what it is.
So croup is a viral illness that affects kids, and it's very common. And parents who have experienced it will also note that their kid, croup it's a viral infection, like I said, of the throat, the larynx area, like your voice box kind of region, but also the trachea and the windpipe. And so what happens is that the virus swells up those tissues, and in you and me, as adults, our windpipes, our tracheas, our larynxes are a lot bigger. So they get swollen, you just get a little hoarse. It's not really a big deal. But when you're, ages like 3 to 9, your wind passages are smaller. And so even a little bit of swelling really narrows them down. And this is like kids that cough and they sound like seals, like barking seals.
Oh,
clank, clank. But that's one symptom of it. But when they're really bad and they have a lot of swelling, then you get the Strider. And then we're like, oh, that kid is sick. We need to do something about it. So yeah, Strider's a bad sound. We never like hearing Strider.
No.
I don't know if Aaron ever likes hearing Strider.
No, I dislike it intensely. The anxiety is not great either. So, I mean, if you're anxious from your breathing, that's in the nostrils flaring is also bad. So when the body's trying to get air to where it needs to be, nostril flaring is one. You can also see their ribs. Sometimes you'll see that little notch at the base of your throat. That'll be very prominent. Little kids, the infants, their head will actually bob up and down, and their nostrils will open up really wide when they're trying to breathe. So there's all this. That would be a sign that he's saying, "Hey, this is not good."
Yes,
I don't like it.
I mean, the nice thing is this physician seems to be aware that this patient's sick.
Yeah.
Yeah, sounds like it. He's like, yeah, he's in a pretty bad way. He also said that his skin was flushed, and he said it was hot, which I'm assuming was warm to the touch?
I'm
I don't know,
guessing
hot
so.
sounds
Yeah, I
maybe
don't.
dramatic to me.
Yeah, I would interpret that as probably fever in the absence of
It's got a fever.
writing down vital signs,
That was
or at least
yeah, that was
sweaty
kind
and
of what
working
I
hard to
figured
breathe.
too.
But either one is, interesting and concerning.
Yeah. And then he said his pulse was full and hard. He was very, very interested in this man's pulse for the duration. There were.
That's not how we describe it today.
No.
Well, I didn't think so. I was like, I don't think they're going to say full and hard anymore. But I ain't no doctor.
If you're a resident listening to this on your next rounds, please don't do that.
Please,
or do
please
it if
do
you
that
get
and
away
then
with
record it,
Yeah.
and then send us the
Yeah, so
recording.
I think what he's saying is it's like what we might call hyperdynamic, meaning it's just like, or bounding would be
Yep,
another word
we'll
for
say
it, right?
Bounding was what I
Like
wrote.
it's
for my
just like
guess.
your heart is
100%.
working hard, like which as it usually does with a fever, and so you're getting this
Yep.
really
Right.
strong pulse, like you can just really feel it. Yeah, his language is a little bit sensual for my taste.
Flowery. Okay, sensual. And then he says like, okay, so his throat appears normal when he looks at it, except for it is tender to palpation. And he says his verbiage was there's great tenderness along the larynx. So at this
Not just
point
good,
he's like,
but great.
Ooh.
yes, it's not good tenderness along the larynx. It's great.
Yeah, so
And-
he's basically feeling. Maybe we'll describe it a little bit. He's like, your guy like an Adam's apple kind of area or whatnot. So yeah, basically if you press on there, I guess he's getting tenderness, which yeah,
That'd be like around the tonsils too, or just
Below.
I was wondering if it was like just on the trachea or like to the sides of the trachea.
I don't know in this case, but
yeah, it's hard to say. Like if you were to right where you were pressing, if you look at your neck and you like lean forward, you'll see a couple of creases appear. And so I'm thinking like through my own voice box, but one of the creases right below the part where you're talking and it goes up and down, that's your larynx, that's your voice box. So whether you have an Adam's apple, which is easily visible, or Alba, if you speak and you can see parts moving there, that's kind of the general area. So it should be right below the base of your tongue here in there. So he's pressing in that general area and it hurts.
the tonsils are
And
higher
I just
up.
happen to know the
Yeah.
cricoid cartilage and the thyroid cartilage
Yes.
in there.
Yes. They
Yeah.
certainly
Good
are.
landmarks
Okay,
to
so-
know,
Very good
especially for
landmarks.
this case.
Yeah, they might come into
Okay.
play later, although maybe not in London. Maybe they'll do something different.
So Dr. Jordan Roche Lynch is like, this guy's definitely sick, right? He looks like he's got it's obviously acute laryngitis. You know what I'm going to do? I'm going to bleed him.
Yes.
Mhm.
So he bleeds him,
Excellent
what
choice.
I interpreted to be 16 ounces. And he makes a note, but don't worry, I was careful about how much I took out. I didn't take out too
It's
much.
good.
Not,
Excellent.
not willy-nilly.
Just one pint out of the 8 to 10. He probably has it. I only took
One
a
pint.
good handful of drams. Yeah,
Yeah,
absolutely.
there you
When
go.
However, this
So
case
far.
proceeds, we are drinking pints as we go through it.
Excellent
Not on
work.
active duty. This happened over 100 years ago.
And he doesn't stop there though. He's like, you know what? We're gonna bleed him one of those pints, and then I'm gonna give you some opium and some other drugs that I did not recognize what those were.
I'll be honest with you. I actually looked into them. I'm guessing he's using abbreviations. And the problem was when I was looking for these, like the opium, yes, he's using some old timey abbreviations, and some of them literally didn't bring up anything that I could recognize. One of them, like antimony tartar, tartarate is probably what that was, but antimony is an really old timey make you vomit kind of medicine. So now this guy has a developing airway issue and he looks sick and scared, and so this
So
doctor
they
is
made him
bleeding him and trying to
vomit
make
too.
him vomit.
Yeah, it's good.
So yeah, this guy has got an airway problem, and basically you're like gonna make him vomit, which is really the last thing I would do.
Yeah, it sounds like a bad idea. So let's take away some of his blood, a whole pint of it, and then also make him vomit, and then also give him opium and check back in on him in an hour is essentially what the plan was.
Sure.
It's a plan, not a good plan, but
It's one though. It is a plan.
It's a plan. I mean, we probably would give somebody pain medicine at least. I mean, that part we probably would still do
That's good.
carefully. But yeah, they definitely, it hurts, sounds like.
Nice.
So then he comes back an hour later, and the trouble swallowing is, he has trouble swallowing, and it's gotten so bad that it's leading him to coughing fits, which are productive coughs. So he's bringing up what is described as thick, ropey mucus.
Mhm.
Great.
Yeah, so seems like he's getting worse. His shortness of breath, trouble breathing seems like it's gotten worse. He's constantly changing positions. And then a clue for me was orthopnea. What I understand to be orthopnea, that when he lays down, he's having to like get right back up because he's gasping fluid in the lungs.
Well, possibly. So,
Okay.
Aaron, what do you think about that?
I mean, that's a good description of orthopnea.
Okay.
I think that this is technically, I don't know if it would still be called orthopnea, but there's something called the tripod position. So when people feel very, very uncomfortable with their breathing, especially upper, sometimes lower too, but mostly upper, they'll kind of they'll sit up and they'll lean forward, and they can't lay back because they're trying to do anything they can to kind of get air into their lungs. So I think that and the unable to find a comfortable position is, I'm pretty terrified right now. If this patient were in my ER, I would be calling an anesthesiologist down to help me supervise an intubation and put him on a ventilator like right now.
Damn.
And this is terrifying because he can't breathe, and he's not
he
like
can't breathe.
that's why he's so restless. And
and that's exactly the same, Aaron. Like, you're driving at it, but like what we're both thinking is, based on what we've heard so far, this guy not only can't breathe, but he's like maybe got an airway obstruction, and his restlessness and like, I need to find this position that will help me keep living tells us so much that there could be something in his airway or pressing on his airway, in that this will be a difficult airway on top of it. In that, you know, in the modern day, we can't just give him a bunch of opium and like check back on him later, because
I mean, it's one of the
guys, he can't, like, what's going to happen if he can't breathe for an hour? You're going to give him something to make him, like, granted it gets rid of the pain, but like, I would imagine that opium would make him sleepier.
Yeah, it sure will.
Yeah.
I mean, it might make this doctor feel better when the patient's resting.
Opium's not. I mean, this would be my last consideration. I mean, people are uncomfortable, so if you're doing everything else, it's quite reasonable to try to control pain somehow, but it's certainly not going to be something and a lot of doctors might not in this case. It sort of depends a little bit. The anxiety anxiety is a tricky symptom. You know, a lot of the times people are very anxious about just being in the ER or whatnot, but anxiety also goes along with, you know, almost dead. So if you get anxious when something terrible is happening to you, so people, like, the anxiety that he's describing here is that very specific dread of like, oh my God, this is going very badly. Please help me. That's
and I can like feel the vicarious anxiety of like the feeling of not being able to get enough air is terrifying.
Mm-hmm.
So what does he do?
Bleeds
he
him
bleeds
more.
him again.
Yes. I didn't believe him the first time. He was a little too
He's
careful,
like, not enough the first time. And he's like, but don't you worry. I'm just going to take another pint. Again, now he's down 2 pints out of the 8 to 10 that he might have.
It's going to help that pulse be less, how do you call it? Was it firm?
Yeah.
Firm and hard?
Less hard and
firm
full.
And hardy.
Hard and full.
The pulse is flaccid now.
So the patient, Mr. Whaler, is like, yeah, I'm feeling a little bit better. And then the diaphoresis happens. So he breaks out in a sweat all over his head and his trunk, his thorax. So my curiosity there, here's my guess. I'm guessing he was feeling better because his fever was starting to break on account of the sweat.
It's possible that was part of it. Or he's slowly losing oxygen, so he's getting confused and he doesn't care, and he's full of opium. So yeah, he might have felt better, possibly because of the fever, but I think the other things were contributing. He's like,
probably the opium.
I'm
there
dying.
is so
and then,
when people
go
are
ahead.
dry, their breathing can actually sometimes improve a little. I'm not advocating bleeding, but for example, if you have some of our surgeons, if they have sort of an upper airway swelling or they're worried about fluid in the lungs, they'll be like, do not give them fluids because they want them to be dry. So, I mean, theoretically with the bleeding, I still don't think it's a terrible idea. Yeah. Never mind where I was going.
You're saying like,
like it might have reduced the swelling a little bit.
Aaron's
maybe.
being kind and trying to give some deference to
No,
this
that's
case.
a terrible idea. Please don't. That's like that's 2 units of blood, a pint.
I know.
Yeah. Oh my
He could have
God.
used those.
So,
It's not going to help him breathe better. Well, I guess it
Mm-mm.
kind of would. More oxygen. Anyway.
He's probably got some
So
extra.
so he's like, okay, he's feeling better. Then he starts getting all sweaty and stuff. And he checks in on his pulse. And guess what he says about the pulse? He's like, oh, the pulse is it's softer. But like, yeah,
Yeah.
you just drained 2 pints of
Yeah.
blood out of this
Good
man.
job.
So
This
The
doctor
pulse
was
was
very
softened.
troubled by the pulse, the amount of pulse, and so he's doing everything in his
It
power
is-
to make less pulse happen. And
He does not like hard pulses.
oh yeah, he's just like, it's too much pulse. We got to get the
That's
blood
true,
out of
that's-
there.
missing the forest for the trees kind of
Pulse is
approach to
way too
medicine.
full. That pulse.
And then the dysphagia or trouble swallowing has gotten so bad at this point that now he can't even drink water at that point.
That's
So-
Aaron and I were puckered a long time ago on this case, and it's just like going so much
Oh.
worse. So much worse. Yeah. So anytime somebody has an airway anything and that they can't swallow, or like water won't go down, or they're drooling, that means that if you are going to try to put an airway in, you expect that there might be something blocking it. And that this airway may not be easy, may be extremely difficult, and possibly not able to get by looking down the throat with our devices and then putting a tube in. I'm guessing this guy doesn't have those devices.
No.
In 18.
Well, you think about it, like
41.
when you drink and something goes down the wrong pipe, right? That's an accurate description. So like your esophagus and your windpipe are like right here, one in front of the other, like that. So, but in this case, we know he has an airway issue because he can't breathe and he's having trouble. So
Yeah.
this thing in the front is all swollen, and now it's pushing backwards into the esophagus, so he can't swallow. So that's awful.
Oh, yeah.
Nothing's going the right
okay.
direction in this case so far.
Yeah.
So he can't. Okay, because I was thinking he couldn't swallow because the pain was so bad. But now if he can't get water down,
yeah.
and
Certainly, you might not
Okay.
be wrong. Honestly, if this, it may be that, but he also might be like, I can't breathe, so
And
I'm
it
not.
looks
Give me water. You're
very
drowning
obstructed.
me. That might be part of it too.
Oh, okay. Yes, that makes sense. So what does he do? Leeches.
Yes.
Yeah,
Bleed
so
him
he's
some more.
bleeding the wrong way. He needed to do organic
He was
bleeding.
like, we can't just let it out. We got to put leeches on there. He put 12 of them on his armpits. In the case, he described it as the axilla.
Maybe the guy could swallow a leech and it would stick onto the part that's swollen and suck the blood out of it.
He could have put him on the throat. It might have done something.
Or
Okay,
don't you worry, we're getting
maybe.
there.
All right, hey, maybe this doctor was like, look, if I take enough fluid out of this guy, he'll desiccate, and then everything will open up.
What does that word mean?
Like dry
Vasicate?
out. Like he'll dry out. He'll be so low on blood that he won't have any fluid anywhere. That might work.
You can't feel bad if you can't feel.
This is like what I was doing before. Yeah, true. This is
Yeah, no, I like the idea of like, we got to put the leeches in the right area because they take the blood from the legs. This is obviously not going to help. So let's put them in the armpits because this guy is having the worst day ever. Can't breathe, terrified, looks bad. Okay, his fever just broke, so let's throw a bunch of slimy leeches in his armpits. We're doing medicine.
They're medicinal leeches,
Yeah.
Max. They're not slimy. They're
Definitely
smooth.
slimy.
So then the doctor's like, you know what? I could use some help on
Yes,
this.
you could, sir.
Okay, sure.
It's
And he
about
calls
damn
up his
time.
friend.
It's about goddamn
Yeah,
time.
it's about time. So he calls up his friend who is also a house surgeon. His name's Mr. Waltham.
Mhm.
And he tells him to come on over because this patient needs a bronchotomy, which is to cut through the trachea to bypass the larynx, because he's like, hey, there's clearly some kind of blockage in your larynx. I'm sorry.
No,
That's Siri.
that face was just
Siri,
the
girl,
recommendation.
you better go away.
He's not
I'm
wrong.
sorry.
Yeah.
In this case, he's probably not wrong. Well, okay, so
Yeah, I haven't heard it
Mind.
called a
I'm back.
bronchotomy, but yeah, I mean, otomy is to make a hole in, right? So, right? Yeah.
yeah, no, you're right. I looked this up because I saw bronchotomy and I was like, bronchi, the actual anatomical would be like if you picture a pair of lungs, you got your windpipe in the middle, right? Goes down, it splits into each lung. And the first place that it splits are like the main stem bronchi. So in my head, I was like, why would you cut through the chest and put a passage into those? That would be so difficult. But honestly, I think in this case, they were saying we need to make a passage into his trachea, probably,
Yeah.
is what
And
they're saying.
Today we'd call it a tracheotomy.
Correct.
Okay.
But yes, 100%. This is what this patient needs.
And I want to point out my favorite absurdity at this point is like when he's calling his buddy, they're not at the hospital for any of this going on to this
No,
point.
he's
They
like-
are
No,
at this
yeah.
dude's house.
It's like, I'm at this dude's house. It's over in Chelsea.
Which, you
just-
didn't
can
like
you
page the
come
guy. You
over?"
sent him a letter by horse-drawn carriage or whatever. And so it probably took 3 days to get, I don't know. But
Yeah,
that
so
blew,
it's like-
of everything that I got so
He
stuck on
said
that
a little
point was
runner.
like-
He ran out into the street and he flipped a little gold coin at a boy. He said, "Boy, go get, hey, urchin, go get this doctor. Go get my friend."
Not going to give the urchin a gold coin. Come on.
Silver coin.
Give him a roll of bread and he's happy about it.
Okay, so he's getting
Well,
the
guess
surgeon.
what Mr. Waltham says so Mr. Waltham's like, all right, I'm coming over. I'll check this out. He gets there, and the patient is still just as bad as before, and he's all super sweaty and everything. And Mr. Waltham is immediately like, dude, we got to get this guy to the hospital.
He's like, what are you doing
He's
here?
like, why is he still here? But the reason he has to go to the hospital is so that he can have a warm bath. And so that he can be and for closer care while he's recovering from the bronchotomy. But he definitely needs
It
that
was
one.
so
Yeah, he
hopeful.
needs a warm bath.
Yeah, I was so
It was like-
hopeful.
He needs a warm bath.
I was like, oh, yay, the
Just-
surgeon. Well, yeah. So that, I mean, I would call a surgeon in this case. I would 100%. If I were in a small place where there's no surgeon, this is something that an ER doc could handle. But in any place that had any sort of surgeon, I would call them and say, "Can you come help me?" Because
Yes.
Well, guess what, Aaron?
yes,
That doesn't happen yet. It doesn't happen for him yet.
No.
He gets there, and the resident is Mr. Harlock, and he prescribes the patient, Mr. Whaler, a warm bath, and you guessed it, more leeches. 20 of them this time, and this time the leeches are going on his throat
Harlock,
because they're
you
like, it
suck.
didn't
This was
work
a
on
Monty
the
Python
armpits.
skit.
You
It would.
We don't
it would
put
work.
these leeches on the throat. That's where it hurts.
Well, at least it makes
you
a
gotta
little
suck out
more
the bad
sense.
stuff.
That
At
makes
least
more
there's-
sense than most things to this point in this case. Yeah,
Yeah.
leeches on the throat thus far, the best idea that anyone's had.
yeah. And I like.
Okay.
I don't think
That's
it's
good.
exactly the same, but I do like the idea, at least the way that this is written, of like, let's get the attending practitioner in the field and then get the surgeon involved, and then we're going to have the resident do all the work.
Yes,
and
exactly.
Defer to them.
That's
And you're like,
what-
no,
It's the middle of the night, man. There aren't any attendings.
Well,
All the
it's true.
attendings
It's
are
true.
in bed. The attendings are like, and back in the day, they probably said, if you call me and wake me up, I will beat you. So,
Yeah,
you know,
they'll be
that-
scared because they won't know what a phone is. So it's be a thing ringing and it's panic.
If you send a carrier
okay.
pigeon.
If you send an
the night.
urchin to my door in the middle of the night,
Just a resident standing out in the street like high fidelity, like beep 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 the window.
help me. Okay, so they've put leeches
So
on the
everything
throat
goes
now.
well from
They
here,
put leeches
and
on
he
him.
does
He's
well.
still no.
No.
Warm
But
bath,
the
the
next
leech bath
morning,
didn't help.
The next morning, oh my god!
the next right, because surgery still hasn't happened. He's been bad for a hot minute now. So the next morning, he's just as bad as he's ever been.
Yeah,
And now there's a new
yeah.
doctor, Dr. Rupel, now, and he sees him and he's like, bro, we got to do this surgery. We got to do the bronchotomy. So he calls the surgeon, who shows up an hour and a half later. But it was noted where they were like, I just want everybody to know that from the time that we decided he needed the surgery to the time that the surgeon got there, it really was only like an hour and a half. So
Yeah,
like,
it's
we
it's
didn't
fine.
like wait too long
Yeah, no.
to do something about this guy's condition.
Yeah.
Unfortunately, so the surgeon shows up to do the surgery, and unfortunately, the patient is so sick that he dies during the surgery. And they described it as expired, or he was expiring at that time. And then they continued to do assisted breathing for a little while after they finished the surgery. After they finished the operation of the tracheotomy and everything, I wasn't quite clear on the timeline of when they were sure he.
Oh, I think it's
was-
well beyond mattering at this point. I mean, the
Unfortunately-
absurdity of this case from a modern perspective is that from the first line that was written about this guy, a modern doc was always like, already like, yeah, we know even if you don't know what the diagnosis is, you're already thinking like there needs to be life-saving intervention from moment one. And this goes over a night, over all the time it took to get these doctors coming and going. And the patient dies, from all of this. And like, that's not the absurdity of how things got carried out is funny for what absurdity is, but like this was how medicine kind of was back then. Life was life.
I like
they did not have an understanding like
I
we
like
do.
I'm going to do an intervention and check on him again. I mean, he
Yeah.
he's like, I'm going to do the leeches and then I'll check on him soon. I mean, that we would, that's still a thing. You still will sometimes be like, okay, well, I'm going to give this patient fluids and see how they do. And we'll check on them. I mean, that's a therapeutic challenge. I don't know what the diagnostic challenge. We'll
Sure.
talk about that kind of concept, but that's in the setting of like understanding what you're doing better than these.
Yeah.
Well,
it's
that's
not
the
that
thing,
these
though.
guys
He understood
could know better
it
with what they have.
I wonder though, because he did understand the case. I mean, he said he was anxious and he couldn't breathe well, and then he knew to call a surgeon, and he knew he needed a bronchotomy or tracheotomy. Like that's so like that. Those were the correct steps. Why did it take him so long? Was it cultural?
And
was
there's something talked about in the remarks on the case, that a bronchotomy. So there's somebody named Mr. Lawrence that says that a bronchotomy should be performed as soon as the symptoms enable us to decide upon the nature of the disease, essentially. But earlier than that, I think it's recommended, someone recommends not doing a bronchotomy until at least 30 hours into the ailment, which would have been like, this guy was dead before 30 hours had passed. So it sounds like there was like debate at the time about when it should happen.
Well, you're describing, so basically after they describe this case, there's remarks like this. So the physician who wrote this case was saying like, this was what happened. Like, and honestly, I think the nice thing is he's actually writing this, like, what could I have done better here? And he's reaching out to the minds who are reading this journal and trying to say, like, what do they think? So at the end of the case, when he's saying basically, I pulled together a lot of the docs nearby and we all kind of talked about it. And then he's getting these opinions about what could we have done differently. And the interesting thing here is that he's getting all these responses. One is like super aggressive on the surgery part, to make a hole in somebody's neck to help like give them air through a tube, right? That's really what they're discussing when they're talking the surgery. And I think we got to remember this. I don't believe we're 1841, right? When is chloroform and ether? So I don't think that. No, I want to say Robert Liston's surgical. I want to say it's 1860s. Or am I wrong? Or maybe late 1840s.
First demonstration was 1846. But then it wasn't. So it wasn't broadly adopted right away.
Right. So they don't have anesthesia.
It's pre-anesthetic.
So all these surgeons of the day and other doctors basically saying, we know we need to put a hole in this guy's neck. We kind of all agree on that. There's some hesitation. I mean, this person is alive, and they're going to feel every bit of that. And that's a procedure we do today with local anesthetic, if not full sedation, if not totally under anesthetic. All of that depending on whatever circumstance. So you have the one guy who's like, yeah, just wait like 30 hours. And then once there's absolutely no choice left, then we'll do it. I kind of get that given what they have at the time. I also do like the guy who's super aggressive. Like, yeah, they have a sore throat, cut it open. Like, no, you're not going to do, come on, man. You're not doing it.
Because and you think about like the risk of doing the surgery, is it greater than the risk of seeing what happens because of like infection? And,
absolutely.
Right. So you didn't have, you had a whole bunch of risks. No antibiotics.
There is something here though that is certainly a thing that still exists in emergency medicine. And so our procedure, if we think we cannot put a breathing tube in the normal way, like through the throat, the mouth, over the tongue, through the mouth, what we call endotracheal intubation. If we don't think we can do that because there's some sort of obstruction to the airway, or maybe we just can't get the tube in, then our move is to do a cricothyrotomy, which is where you go through the cricothyroid membrane into the trachea, into your windpipe. And we're trained to do it. We practice it. We practice it on a variety of ways. Aaron, have you ever had to do one?
Yeah, we have.
And we all, I've been part of one. Like I've helped with one when I, in residency. And so, it's technically maybe not as difficult as we all think it is, but the making the decision to do it when you know that you need to do it, that sometimes is the barrier that we all work to get over, right? And so these guys, I think the nice middle ground is, and I do think the guy who's on the aggressive end, what he's really probably saying is, when you know your patient is so sick that they're going to need this, that's when you should probably do it. I think that's truly what he's saying. I'm joking when I'm saying he's like, oh, you got a sore throat, let's do it. But
Cut it open.
I think what
Cut
he's
them all
saying
open.
is, when your patient is looking like they are trying to get comfortable to breathe and they're drooling and they have this horrible throat infection, that's probably the decision point where you should do it before they are 30 hours in and looking as bad as this guy did.
And what I appreciated about that comment in the notes was that he said the condition of the patient is more the criterion than the period of the attack.
Right.
I was like, okay, yeah, that's like focus back at who's the person in front of you.
Correct.
That's, make your decisions based on the person.
Yep. So I think it'd be a good pivot to talk about, what was this diagnosis?
So
Well,
definitely. So acute laryngitis on account of the, maybe laryngitis. Actually, I don't know, because are the vocal cords described in this?
I think they actually are.
So autopsy.
Yeah, let's go there.
Because I saw pharynx, but I didn't see him actually say in there. He says, on bringing the sides of the glottis. Oh, wait, before the glottis.
He uses some more sensual language.
Oh my God, yes, we get some sensual language. People buckle up. Here it comes. So the epiglottis was erect.
It sure was.
Thickened. And it was in such a state as to be incapable of protecting the glottis from the content of matter passing into the pharynx.
All right, let's stop here.
Me,
does he say thick with
yeah.
2 C's? Is that?
So I was going to say, going back to what Aaron was saying earlier when we were talking about trouble swallowing or not wanting to swallow the water, if the epiglottis is incapable of protecting the matter from passing into the pharynx, that means that as he's trying to drink water, there's probably water going down his windpipe too.
Mm-hmm.
So it's possible.
That's a good point.
We should talk about what the epiglottis does, because I think that'd be
Oh.
important for the person listening.
Yeah. So if you feel your Adam's apple and you're talking through it, that's your larynx. And the back end of that, there's a little fleshy, I got to be careful with my non-sensual language, mucosal sort of flappy thingy that's usually quite,
You know what it looks like? Here, I just thought of this. You know those trucks that have the smokestacks where they have the flappy
Yeah.
caps?
Yeah.
That's what it looks like, but it's a meat flappy
like.
cap
Yeah.
for your windpipe.
But it's
a meat flappy cap.
It's a meat flap. And so when you go to swallow, that little meat flap will go boop and like go forward over the top of the windpipe to protect it, so that when you swallow, you can't get anything in the windpipe. And then when you breathe, it flips back out of the way so you can breathe, and it kind of sits on the back end of the opening to the lungs and right above where your vocal cords are. Yeah, it's kind of cute. It's just a little thingy.
It is.
So it does the work of determining which direction the stuff is going to go.
It's sort of like, yeah, it sort of caps off when you swallow, it caps off the opening to your windpipe. And then you swallow whatever food or drink you have, and then you breathe out, it opens up again. So it's basically like a flappy valve that tries to protect your airway from stuff.
So when something goes down the wrong pipe, you usually just like go too fast for the epiglottis to flop down.
Yep.
Thank you, little floppy thing, for doing all that work.
Yeah.
It's a lot of work.
Now this guy, he's describing this. I will be honest, I don't know what you made of this, Aaron, but the description of this was, when he's talking about how it wasn't able to protect, I didn't really know what he meant by that. Because what I'm seeing is when he says the epiglottis is erect, thickened, and whatever, it's a big, swollen epiglottis, which we don't like, because you want that flappy meat valve to be nice and flexible and not gigantic to the point where it's covering things it shouldn't be covering, like your windpipe. And so as part of my reading of this case, I don't, this is part of it, but I don't know if this is the diagnosis. And the diagnosis I'm dancing around is something called epiglottitis. And that just means swollen epiglottis. And it's a very real and scary diagnosis that we fortunately see rarely nowadays, but it is definitely a thing that's kind of making a comeback here and there. But that's where the epiglottis itself gets so swollen that it blocks the airway. And like usually patients are drooling, they can't breathe, they can't swallow. It can change the way their voice sounds because it's like literally this big, it goes from a meat valve, like flappy valve, to a giant meat drumstick that is just like closing off the
or
airway.
it'll swell all the way around.
Yeah. So now I think that could be the diagnosis here, that it was epiglottitis, but there's some other things here that are interesting that make me wonder about that. And what did you think, Aaron?
Yeah, epiglottitis would fit this the best in my opinion. That's what it sounds like to me. So laryngitis. So you're gonna have. So the itis just means inflammation of. So like when you have this epiglottitis, I think it's named that partially because that's where the main pathology is, but you're still going to have inflammation of the larynx, and you're going to have, you're still going to have laryngitis along with that. But if it's only the larynx that's swollen, you usually get just stridor. So there could be some, laryngitis or tracheitis as well, like kind of a bacterial infection of that whole column. Maybe there's a blockage further down on the other side of the vocal cords. That could be too.
So basically any of that system that's inflamed is going to be itis. So maybe he had some laryngitis and some
epiglottitis.
Yeah.
Epiglottitis.
There was another thing that was interesting here, and that's why I wondered if it was truly just pure epiglottitis or something else. So when he's talking about, I think earlier in the case, he's talking about the stridor, where you got that narrowed airway sound, which you can definitely get some of that with epiglottitis, no doubt. And then a bunch of ropey secretions, like this guy's coughing up tons of gunk. You can definitely drool with epiglottitis, but it's usually not like a super pus-making infection, generally speaking. And so that was interesting to me because it raised another question of something we call tracheitis.
Yeah.
And again, it's brilliantly named tracheitis, so swelling of the trachea. And that is typically comes with lots of gross pus, coughing up stuff. And it's something we don't see a ton nowadays because we have vaccinations. And one of the things that kind of causes epiglottitis and causes tracheitis back in this time period is a bacteria. Not the only thing, by no means not the only thing, but a very common bacteria that maybe fits this bill. It would be like Haemophilus influenza. And
that's your H flu vaccine. Get your vaccines, everybody, if you don't want
vaccines. So Haemophilus influenza is actually a bacteria, but it was misnamed because of the influenza part. Because I read this really briefly a little recently, and it was like he described a lot of features of Haemophilus infections, but it happened during influenza season, and so he called it Haemophilus influenza. But this is a bacteria, and it can cause a lot of like really mild stuff, like, runny nose, sore throat, ear infections, that sort of thing. But back in this time, before they had vaccinations for it, and even other bacteria like staph, etc., could cause these wicked infections of the epiglottis, of the trachea. Lots of pus certainly possible in them. Even this bacteria can cause meningitis, infection of the brain. And so this,
yeah, it's a good point.
A lot of it.
Yeah,
we don't see a lot of it.
Well, epiglottitis might be more of a like less coffee phlegm and more hot potato voice first, and then as the swelling gets worse, you start to occlude the airway a little bit because you have all that swelling just at the epiglottis. It's a good point.
Yeah,
very well could be.
He says that he could only speak in a whisper, and I don't know what hot potato voice is, but I'm curious.
Mm-hmm. So if you a lot of throat infections, like sore throat's one thing where you're like, it just hurts to talk, but certain throat infections that can cause swelling low by your voice box can change your voice significantly. So like if I press, I know if you're listening to this, you won't see this, but if you look at the video, if you press on the side of your voice box, like this, like
wow, look at you. That's a great hot potato voice.
Then
impressive.
Oh wow.
Or if you had like, let's say, the other possibility here would be a abscess in the throat. So a pus collecting abscess at the back of the throat, what we call a retropharyngeal abscess or whatnot. So if you have something that is pressing up both sides of your way and you try to talk like this because of sort of swelling, that's we can't tell from what we read here. I don't think we can know exactly what this may have been. It certainly could have been either of those things, but anything that's going to be down and around your voice box area and causing swelling could change your voice. What we call hot potato voice, we often associate with something called a paratonsillar abscess. Just, again, another back of the throat pus collection that causes a lump of swelling that when it does start to press it starts to change the way that your air moves through your voice box. Anytime you have an illness that changes your voice in that way, at least it perks our curiosity.
Mention his dentition either. So, but he's in London, so it's probably bad.
Ouch!
Bad,
Shots fired.
I mean, it's 1841 London, so
dentition
1841
means teeth.
anywhere.
Yeah,
I know that.
So you can
just putting that out
get
there.
the bacteria that live in your mouth normally are not great. So if you get infection in the lower teeth that kind of goes down the throat, you can get what's called Ludwig's angina, where it just kind of swells and goes all the way down the throat, and it can also occlude your upper airway. Usually you would have a different description than this. Like you would have swelling under the tongue, and the tongue would be high. And so actually, now that I think of it, like he said, when I looked inside the mouth, it was normal. You normally wouldn't see that with Ludwig's angina because the tongue would be all swollen up, and then it goes down from there, and it can just like work its way into all the spaces around the neck and block your airway that way. But that would be a poor fit for what he's describing, because he says when I looked in the mouth, it looked normal. So
yeah.
I do want to point out what y'all were talking about with the inflammation of the trachea, tracheitis.
Mm-hmm.
It does say on bringing the sides together, the glottis was intact. The natural opening was completely obliterated by the thickening. So I wonder, I didn't just want to read that again.
He's like, oh, it's such a beautiful swollen epiglottis.
He wanted to put the word thick in there a couple of times. But it says it prevented respiration. And so it sounds, I feel like he could be describing the trachea there, maybe?
It's hard to, I know exactly what you're reading. And I read through it going, I can't tell what's exactly swollen based on his wording. Was it, when he said the obstruction there, was it like right where the larynx becomes the trachea? Was that so swollen that it was, obliterating airflow? Was it, he didn't describe the larynx as being that. So I don't think that's really what it was. He's talking about subglottic, like meaning below the glottis. It's like right below the vocal cords. Was that so swollen that I wasn't sure?
But is the epiglottis different from the glottis?
Yes. The epiglottis,
so the
epiglottis means above.
Is the flap.
Yes, the epiglottis is the flap above.
The tube.
Yeah, the glottis is oh god. My anatomy professors are listening.
I have
the exact
I have a
borders
anatomy.
of things.
I'll check.
No, I do too, and it's going to stay over in that bookshelf. So generally I think of the glottis as the opening of the vocal cords right as you move from the pharynx, that meaning the back of your throat, into the windpipe structures. Like that's kind of generally what I think.
Oh, gotcha.
Subglottic, so below glottic swelling, so downstream is bad. It's always really bad because there's not a lot we can do for it. And so if you have narrowing of structures below the vocal cords, the glottic area, then you have problems. You have a lot of problems. And so by making a hole in the neck below all of that stuff, you're trying to go past it. And you're trying to be like, all right, even if we have surgeries where you can remove the entire voice box, laryngectomy, and then you get a permanent connection between your trachea and the skin, so tracheostomy. And so you can live without a voice box, but you have to have air moving through your trachea beyond that. But this is an acute illness in 1841, so you're really pinned. Nowadays, if you had any kind of, let's take out all the surgery really badness of this case. If somebody has an H-influenza infection, which can happen from time to time, you give them an antibiotic, and they didn't have that option here. So even if he showed up and this guy's bad and all he could do is get an antibiotic down, then maybe things would go better. But even then they didn't have that option. So this is a tough case for them.
Looking at a lot of Google images here, and it looks like the glottis is the space between the vocal cords. So,
there you go. I danced around it, but I kind of said
Now,
No, you got it. I mean, I had to just look because I was curious.
so essentially, this guy he was going out no matter what.
in 1841, he
situation,
absolutely was.
Yeah.
he was going out no matter what.
Yeah,
He just had a rough ride on the way out.
the best case scenario,
the
if
leeches
they
and-
had the super aggressive surgeon that did the airway initially, and the guy didn't die from the fact that they did not do surgically aseptically, so he could have more likely had the infection. It is still pretty likely that this guy would have died from this infection because it's
She
just
would have gotten a tube in there, so he could have breathed through that, but then the infection would have just continued.
right.
I mean, sometimes epiglottitis will pass on its own ish. I don't know what role antibiotics play in that passage, but like the epiglottitis part, you put the tracheostomy in and then you treat the antibiotics and let that pass. And then when it goes away, then you take the tracheostomy out. So this guy was going to have a really rough road regardless. I mean, I think,
Well, if that about does it, Alba, as our show's tallest ever medical history intern, how will learning what you've learned here change your life from this moment onward?
I will not trust anyone that says that something is obviously this diagnosis, because it was not. He said it was obviously laryngitis, but then later we discovered not necessarily. And bloodletting was like really popular for something that really didn't do anything at all. And
It made this guy's pulse less. It did something.
or made it worse. Yeah. And so I will not trust anyone ever again.
That's
there
exactly
you go.
the moral of the story.
There you go.
All right, we got you there.
Yeah.
No, I think this was a pretty cool exercise. I mean,
it's interesting you brought out the, saying always he was not humble. This is a case to be humble. You get all the friends you can. You be very careful. This is especially for residents listening. Like this is when you don't cowboy this one. These are the kinds of cases where you want friends and you want to be really careful because it will humble you, but the patient first. And that's not a good feeling. Ugh, scary.
Yeah. Well, hey, with that note, we hope everyone enjoyed this episode. And if you did, since this is a new thing we're doing, let us know. Like, shoot us a message through our website, www.poorhistorianspod.com, or go through our social media, send us a DM, and tell us if you like this, if you enjoyed this, because if you do, we'd probably be inclined to keep doing these. Alba, I hope you had fun too. This wasn't painful, was it?
No, I had a great time.
Yes.
I'm just gonna think about all the ways my body can fail me.
We have achieved our goal. Constant anxiety
how much time you got?
about what can go wrong.
We have so many other ways we could talk about.
This
So
was
maybe we'll
in
save it for
less than
future
a
episodes.
square. This is only a couple square inches of your body, and it's just
absolutely
5 different ways to go wrong. It's perfect.
For any listeners out there trying to grapple with their existential dread at this moment, please feel free to join us for our regularly scheduled Poor Historians podcast episodes, releasing every other week. If you want to find us on social media, check our link tree on the show notes here and give us a follow. Help us grow our community of medical history aficionados. If you have time, go and give us a 5-star review on Spotify, iTunes, or wherever you get your podcasts. And until next time, Poor Historians will be signing out AMA.